Sir, we'll finish presenting this protocol, sir. Then we can discuss all the questions and concerns, sir. So, good afternoon, everyone. So, I'm Dr. Pradeep from Bangalore. So, I'll be presenting the protocol. So, this protocol is ratified by a scientific committee, sir, for all of you. So, scientific committee was constituted under the Honorable Vice Chancellor of Rajiv Gandhi University of Health Sciences. And whatever we are discussing today, the first protocol is ratified by the scientific committee here, sir. So after that, we'll present the sepsis protocol, which has also been submitted to RGHS, and we can follow that as of now. And then ventilation protocol, very briefly, we'll cover, sir. So this is an algorithmic approach. So there are two protocols you would have got. One is the word format from the government of Karnataka. So it is pretty much what I'm going to talk, which is put in an algorithm, sir. The treatment starts with any patient who is asymptomatic, or if you see the guideline, it says asymptomatic or mild symptoms or moderate symptoms. So it is divided into three levels: category A, category B, category C, which I'll talk in the next slide. So the reason I put up this in a pictorial way is to understand what are all the mild symptoms, because that is something which we need to have a sort of a high index of suspicion to pick up these subtle signs. Because even in yesterday we discussed about the patient so-called we call as asymptomatic, when in retrospect you ask them for some symptoms, they may have some mild symptoms, and that can be simple headache, or it can be some nausea, vomiting with hemoptysis, some blood streaks, and they can have simple muscle aches. And these are the statistics, like 14.8% can have muscle aches, and some people can have diarrhea. 3.7% is what has been identified as having diarrhea. And fatigue is a very significant. So I know it is very non-specific, but in a patient where you would suspect he's a contact, and if even a fatigue becomes a mild symptoms. For the earlier question you asked that they are asymptomatic, so the simple fatigue also becomes pre-symptomatic or symptomatic. And X-ray 59% of the time in COVID can pick up some subtle signs or features. And the classic example we have seen in across the districts is where patient has been walking around, but we have seen an X-ray presenting with huge patches. When you do a CT, it shows like a mild ARDS. So we need to have a high index of suspicion and a very watchful eyes to look into the X-ray. And CT, if you are able to do for any patient, CT has a sensitivity of 86% to pick up the signs. So and the ARDS, what we talk about, is in a very small percentage of patients. As you see, it's only 3% will tend to have respiratory failure with ARDS. The typical ARDS, where PaO2 FiO2 less than 300, what we define, happens in a less percentage. So we need to have a watchful eyes, vigilant eyes for all these non-specific symptoms like headache, fatigue, muscle aches, and sore throat, cough, little hemoptysis, and nasal congestion, and anosmia is also been identified now, and diarrhea also can be the symptoms. So the way we have divided is group A, as you would have seen in the protocol, is mild symptoms or asymptomatic. So that's why we have clubbed this together. So mild symptoms, and I will tell you the rationale as to why we advocate treatment for asymptomatic. So that we will talk. The reason why we advocate is because these asymptomatic can spread the infection, can transmit the infection to others, and the literature evidence has shown that they can transmit infection to more even after a month. So 36 days has been the maximum recorded published time where they can continue to spread infection to others. The reason why we agreed upon treating asymptomatic was to mitigate the spread, because if you vouch for that French trial that came, they said by treating them you can abort this shedding of virus by 7 days. So that is an intent that we tend to treat, so that we don't allow these patients to transmit infections once we go to a home quarantine stage, because eventually as the surge happens we may head towards home quarantining this mild asymptomatic, and we don't want this patient to spread to other patients. That's why we have advocated, we have agreed upon that we should treat these patients. And group B patients is who is slightly tachypnic, respiratory rate is 15 to 30, where saturation is hovering around 90 to 94% on the room air. And group C are the sick ones who should go in a monitored place, maybe ICU or HDU, where respiratory rate is more than 30 and saturation is less than 90%. So these are the groups of the patients that you could stratify when you see the patient presenting to you with COVID positive. And in all these patients, there is a standard set of investigations we have suggested, which includes complete blood count. In complete blood count, we really want each one of you to look into the lymphopenia, lymphocyte percentage less than 7%, or neutrophil lymphocyte ratio. Here the ratio what I put is a changed version. So now we look at a ratio anywhere more than 15, 17 is the evidence-based number that now we have agreed upon. So more than 15 you can keep your alarms, as this is a patient who potentially may have a bad outcome. So neutrophil lymphocyte ratio, so every patient would get a complete blood count, and you can simply do the ratio and look if the higher the percentage, lower as the lymphocytes, and bad would be the outcome, or you should have a high index of suspicion that there is a potential for these patients to worsen. And for all these patients, we advocate doing blood urea, creatinine, electrolytes. And for all these patients, ECG, the reason why we put ECG as a baseline test is because you would start them on hydroxychloroquine or azithromycin and few other innovative drugs, and all these drugs can prolong your QTC. And this is all the more needed for anyone with comorbid conditions. So we advocate baseline ECG because there are some genetic variations where QTC can be prolonged. So you can take this reference, what is indicated less than 470. I think in the protocol you'll see 500, that is fine. But if you want the exact number, less than or equal to 417 males and less than or equal to 418 females. So once you have identified this, the first thing, as Trilok sir said, all patients have to be monitored for the saturation. That's why you'll see upfront in the protocol, we have put the saturation as the key, because 50% of the COVID patients, as per the literature, can be silent hypoxemic. They are even called happy hypoxemic because they have absolutely no symptoms. And we have seen in our own rounds that these patients are happy because the Chikballapur patient was walking around nicely and he had saturation also present. But when you saw the X-ray, he had a sort of ARDS sort of a picture. So we should have a really high index of suspicion in picking up these early alarms. And if your saturation is more than 94 or equal to 94 on room air, please monitor him, but you can be little comforted and look for the other alarms. If it is less than 94%, then you have to be a lot more vigilant and put them on. Definitely all the patients we would recommend continuous saturation, but less than 94, depending on the facilities, less than 94, definitely we would advocate put them on continuous saturation to keep a very close eye. And as per the protocol, for all these patients, we are sending the alarm markers. So as I said, in algorithm, although it says only for less than 94, for all patients, we are sending the alarm markers. So what are these alarm markers? D-dimer is very important test that we advocate, ferritin, LDH, troponin and CRP. The rationale, I'm sure all the districts must be wondering what is the rationale, why we are asking for this alarm test. So the reason is there are certain scientific literature which has told us as to why this becomes alarms. So if you look at this study which came in Lancet in 9th March, so the odds of them having a bad outcome with high D-dimer is very high. Like if you see the odds, it's 18.42 if D-dimer is high, which means to say any of your patient where D-dimer is high, it is an indication that he is a vulnerable for having a bad outcome. That bad outcome is worsening to going to ICU, worsening to need escalation of respiratory support or even dying. And age also becomes an important factor. So this is the descriptive graphs which show any patient. Why we emphasize so much on neutrophil lymphocyte ratio? Because the patients who have lymphopenia, their survival was low compared to the patients who did not have lymphopenia. The blue graph is the one who survived, and the red one is the non-survival of patients who had lymphopenia. And why ferritin is important? Because even if you see patients with high ferritin had a poor survival. The red graph is the patients who did not survive, as opposed to the blue graph where serum ferritin was normal and they all survived. That's why we put so much emphasis. And high sensitivity cardiac troponin, if that is not there, just do a troponin. Again, if troponin is high, it is indicative of they can have myocardial dysfunction or myocarditis, which again portends non-survival. And LDH, because these are the graphs which is come in Lancet article, which has clearly shown us that these are the independent predictors of bad outcome or poor outcome or poor survival or mortality. And so again, going to the most recent article that came, the JAMA article, based on that, we have revised the NLR ratio. That comes from a 12th May JAMA article. It's come only few days back. There they have done a multivariate regression analysis in a group of patients, up to 1000 patients. And again, they found age, anyone coming with you with an obtundation or anyone who suggests they have a hemoptysis or who have an underlying cancer history, they have a very bad outcome. Their odds of dying or going on a ventilator or poor outcome is almost up to 4 times. And abnormal chest X-ray, if you see at the outset, they also have a bad outcome. And what I want you to see in this multivariate regression analysis that came in JAMA was NLR. Here they have identified NLR ratio, the number they put is 17. So anyone with 17 and above had a very poor outcome. So they either died or they ended up on ventilator. That's why we revised that 3.5 was based on earlier studies. Based on this latest article, we have revised this NLR ratio of 17, and LDH also they have put a number at 480. So 480 as a cutoff. So you can take 450. So you can exercise your clinical discretion. So anyone above 480, they do have a very bad outcome. So that's why during all our tele rounds we keep telling what is the NLR ratio. So for me, you don't have to absolutely stick to this number based on this paper, but you can keep higher the NLR ratio. If it is say 15 and above, then you know you have to keep a close eye, because there is every possibility that these patients may deteriorate, or LDH being high, they could deteriorate. And D dimer, the reason is D dimer is a predictor of prothrombotic state. These NLR, LDH, ferritin are markers of cytokine storm. So that's why for us to decide what intervention to do in the form of steroids or in the form of anticoagulation depends upon D dimer or this cytokine storm, which are indicated by LDH and by ferritin levels. Right? So this also we have incorporated in the guideline. If you look at your Karnataka government guideline, we have put a reference of this JAMA article. So it's a very simple online calculator. If you do not want to remember any of the numbers, that is fine. You just click that link that is given, which is being projected there, and I can send you the link to all the groups. So you can just press the link, this online calculator will open. Here see, it factors in all the risk factors for poor outcome. It factors in the X-ray. See, this is an arbitrary numbers I put. X-ray abnormality I put S, and age I put at 60. Hemoptysis, generally none of our patients had hemoptysis. And dyspnea I put S, some of them have dyspnea. Unconsciousness I put as no, because we have not seen any patients coming with obtundation. Cancer history I put as no, and NLR ratio I have just put 18, LDH I put as 480, and bilirubin I put as 2. And if you see, it gives you high risk. So it gives you a risk, high risk. So at least you know these are the patients who are high risk, who need to be given more emphasis, more vigilance, and more closer monitoring, and maybe they may need additional intervention. So I would suggest, rather than you trying to remember all the numbers, all of you I'm sure will have smartphones. So if you can just click on the link, go to this calculator for every patient, put in these variables, and even for us to do any research, it would be extremely easy, because I've sent you a research pro forma in our group in the districts we are doing. So if you can fill based on this calculator, then we are intending to publish a paper as to how our outcomes have been. So it will be a even good research tool for us to do some studies on this. So if saturation is less than, if your patient comes with saturation less than 94%, then that's a patient which is a worry. He needs to be monitored. So put him on an oxygen. So you can put him on nasal prongs at 2 to 5 liters or 5 liters if he is very tachypneic, and see how the response is for the oxygen that you have given. If saturation is nicely improved, you can observe him closely. If saturation is still less than 94%, he is very sick, then you can send. The reason why we have advocated blood culture is to look for any other infections. You can send the septic screen, blood cultures, gram stain culture, and then you may have to move to non-rebreather mask, or if you have a high flow nasal cannula, put him on a high flow nasal cannula, because this is the time that we have to really put in a lot of efforts to make sure that he doesn't deteriorate to go on a ventilator. I'm sure even in the last presentation I have said, our whole effort is to prevent them from growing on a ventilator, because once they land up on ventilator due to respiratory reasons, non-respiratory is fine, because we had one patient in Bellary, he was obtunded, his consciousness was low but saturation was okay. Maybe they may benefit, I don't know. But if they are worsening due to respiratory worsening, like even if you put them on high flow nasal cannula at say 60 liters and FiO2 of 80%, and they are worsening, then you put them on ventilator, we understand that his outcome or mortality is going to be very bad. So if your places have HFNC, put them on HFNC as a first choice, because your aerosolization can be kept to minimum. If you do not have HFNC, this question gets asked to me again. If you have NIV, please use NIV, because we have saved lives by putting patients on NIV. But when we say NIV, even yesterday I told to all my districts, we don't mean the small BiPAP machine we use at home. NIV machine, when we say, what it means is an ICU ventilator with an adaptability to use NIV mode, with a two-limbed circuit with an expiratory filter put on the expiratory limb. So that's what we mean. So it's not that small BiPAP machines which were intended to be for home use. We don't mean that, because these are sick patients. They need to be ventilated with proper ICU ventilator with an NIV mode, with our ability to adjust the FiO2, with our ability to adjust the PEEP, with our ability to adjust the inspiratory pressure. So that's what we mean. So that I wanted to absolutely clarify, because with that ventilator we can save lives, because there's a lot of data emerging that non-invasive ventilation in the absence of HFNC is the way to go to save these patients, because we are able to understand these ARDS better with this. Once your patient has gone on a HFNC or NIV, I think that is where our efforts have to intensify, because they need lot more closer vigil, lot more closer monitoring to look for whether your NIV or HFNC has led them to get better. So how do you find out? You will see whether his tachycardia is coming down, whether his oxygenation is improving, whether his hypertension response is coming down, whether his tachypnea is coming down. If these things are not happening, on the contrary, you see there is a worsening oxygen despite you putting them on HFNC, and you see after having put him on that, he is getting more drowsy, and he has accessory muscles of breathing. You can just look at sternocleidomastoid and see if there is a worsening of accessory muscles exertion, and if he still continues to remain tachypneic, tachycardic, and hypertensive. And obviously, once they go to this stage, another thing that I see is ABGs. I think we need to be very liberal in doing arterial blood gases, especially when they go to this phase, because we need to see whether oxygen is improving, pH is getting better, carbon dioxide is coming down, acid base is getting better, because that tells us that is getting better and is showing response to the intervention we are doing. If that is not happening, then we may have to intervene with other modalities to save a life. So this becomes a quintessential critical step that we need to pay attention to and intensify our efforts at this stage. So that's what I mean. So why we are so much emphasizing on that previous slide? Because of this reason. So this JAMA article, which came as late as 22nd April, this involved around 5,000 patients in US who were ventilated, who were in ICU, and they found in the patients who are intubated and mechanically ventilated, 320 patients who are intubated and mechanically ventilated, mortality was 88%. So in the best of the advanced world with advanced measures, if the mortality is so high, so our understanding is we should put in our best efforts to prevent our patients from going on a ventilator. If they go, that is fine. We understand he's very sick and death was imminent. But our whole efforts are pre-ventilation, putting all the best efforts to make sure that they don't worsen to going on a ventilator. And this was another Chinese article which came prior to this US article. This came in Lancet. There also you see 97% was the mortality when they went on a ventilator. So that's why we all understand here as experts that our whole intent is to prevent them from going on an intubation and mechanically ventilator. And this was again an Italian study which showed their mortality was more than 65% in intubated and mechanically ventilated. And if you have to intubate, yes, we have to intubate. So obviously we re-emphasize that patient has to be on a full PPE gear for us to before we intubate. And then you have to go on to our ventilation protocol, which I will talk about later. So, and with regards, that's about your supportive management for the hypoxemia respiratory failure. Treatment for all the three groups, the treatment is mandated. See, I put a disclaimer in our algorithm for all the districts. None of the treatment modalities we are suggesting are magical therapies which are conclusively evidence based, because as of now there is no strong evidence to say any of these drugs what we are mentioning will change the outcome based on the evidence. But these recommendations are based on the current prevailing evidence and current guidelines. So if they have fever, obviously you will give paracetamol. So hydroxychloroquine, you know all these dosages, I don't need to reiterate, 400 mg. So these are all as per our standard ICMR guidelines. And if their saturation is less than 94%, which comes under category B or category C, we say give injection vitamin C as opposed to tablet vitamin C in asymptomatic or pre-symptomatic or mildly symptomatic. And oseltamivir, based on your index of suspicion of H1N1 suspicion, if the swab comes negative, you can stop oseltamivir. In all this category B, category C who are sick, we advocate giving ceftriaxone. In all this moderate and high risk, we advocate enoxaparin 40 mg. The reason we advocate is all these patients have been found to be in a prothrombotic state, where they have a risk of microthrombi formation. That's why all these patients who are on oxygen should be on enoxaparin or dalteparin, whichever is available. But in all district hospitals, I am told enoxaparin is freely available. Please give 40 mg subcutaneous. If D dimers are very high in these patients, then you will be discussing with experts. Then we would advocate therapeutic anticoagulation at 1 milligram per kg as a choice. So as I mentioned, so these are all the experimental drugs. There is no conclusive evidence to say these are helpful. But obviously, when you are doing rounds with the experts, So if the experts find that your patient is on a high oxygen requirements with any of these alarm markers, I think that is when you would see us suggesting that start anticoagulation with enoxaparin, and at some stage where we see ferritin is very high, LDH is very high. The reason we start methylprednisolone is to mitigate the cytokine storm, because ferritin high and CRP high and LDH high indicates to us there is a cytokine storm. So to abort that cytokine storm, that is an intervention for us to do, where we suggest 1 milligram per kg of methylprednisolone, and this is reasonably, everyone is following this at this point of time. So we could give 60 mg methylprednisolone, preferably as an infusion over 24 hours. Lopinavir, ritonavir, the evidence is fading away, but on compassionate grounds, if a patient is sick, experts can guide you if this also needs to be advocated. Remdesivir, currently it is non-available in India, but as a part of ICMR trial, if the drug becomes available as a part of trial, you can start using it. Convalescent plasma, again as a part of trial, BMC is doing it. So if any of you are interested to be a part of the trial, you contact the authorities, get the trial approved in your institute, and you can consider using this. Sepsivac is freely available, but again, these are all not magical drugs. So these are used in a situation where we want to prevent them from further worsening. So Sepsivac, I'm sure many of you had questions what this is all about. So again, Sepsivac is works a little bit like tocilizumab. It has an effect on reducing your cytokine storm, and in specific IL-6 level. See, the tocilizumab that we have suggested in your protocol also is a IL-6 receptor antagonist. So it tends to reduce your IL-6 receptor, which is found to be very high in these patients. So Sepsivac also is having a similar modality to reduce the cytokine storm. And right now, as we speak, this trial is happening in All India Institute of Medical Sciences, Delhi, Bhopal, and Chandigarh, PGI Chandigarh. So results are awaited. So it's an off-label indication. It's a DCGI approved drug. So if we have to use it, you can discuss with an expert. And when there is a consensus, this drug with Riloxar's help, we are making it available in at least few nodal centers. The only good thing why we incorporated this drug is we are able to get this drug free of cost. Otherwise, it will cost 21,000 rupees. And even the tocilizumab is an expensive drug. It costs up to 50,000 rupees. So since we are getting this drug free as a as a benevolent endeavor from the pharma, so we intended to have this as part. But this needs the approval of an expert and a discussion and a dialogue before we do not want to use any of these drugs indiscriminately. So it needs to happen after a due discussion with experts or your local expert team in consensus with the teams. I think that would be the way to go about. So criteria for discharge, I'm sure you're all aware. So right now we are still adopting, we have not adopted the ICMR criteria for discharge. So our criteria still remains as what it was. So we need 2 tests which come negative after day 14, 24 hours apart. We are still adhering to that. This may change and we would let you know. And these are also very important. So for all the patients who are on azithromycin, oseltamivir or chloroquine, we need to repeat ECG, especially in elderly who have cardiac problems, to see if there is any QT prolongation. And if there is any QT prolongation by more than 60 seconds, you need to stop and discuss with your experts. And in all the elderly, more than 50 who have ischemic heart disease, who are on HCQ or azithromycin, please try to maintain serum potassium more than 4 and serum magnesium more than 2. Because today I was doing round in Hassan, so we had a patient with VPCs, premature ventricular contraction. So they are at a risk of having arrhythmias. So it is important that we monitor these electrolytes, magnesium and stuff like that, just to make sure that we could mitigate the risk. And these ancillary measures also are very important. In ICU, not only the specific treatment, so we need to take care of them with lot of supportive measures. Please feed all your patients. So we don't want any patient to be kept NPO, because we had one patient in Hubli, Akbar, who had undergone a surgery, ileocecal anastomosis. So there we kept re-emphasizing, because feeding is the only way that we can improve his conditioning, and that has shown to have significant impact on their outcomes. So please feed. No one should be NPO, and generally we don't advocate any routine IV fluids. So you can just allow them to have as much feeds unless they are hypovolemic. There are clinical signs indicating to hypovolemia. Then we advocate fluid resuscitation. So in intensive care parlance, there is no concept of maintenance IV fluids. And if they are diabetics, make sure you are maintaining sugars less than 180. And this is the fourth one, is a quality marker. It is not a simple thing. It has an extraordinary bearing on improving their outcome. Please keep all your patients who are needing oxygen in a complete propped up position. because that optimizes your lung function, it enhances the recovery, it improves your sputum clearance, and it has a multimodal effect in improving their lung function. So please keep your patients propped up. And the Bagal coat, I should really upload your patient, because anytime you send me a video of a patient, I see them doing spirometry, and we see how dramatically he has improved. He was a very sick patient who was needing 70% FiO2 on HFNC, and today he is able to move the third ball. So incentive spirometry, we emphasize, there is a good evidence for how incentive spirometry help improve their lung function. So please don't underestimate the simple archaic measure. Incentive spirometry is something we would advocate for all patients who is on oxygen requirement to improve their lung function. And net neutral fluid balances, we really don't want them to be overloaded with fluid, especially when they're on oxygen. So net neutral is cumulative fluid balance. We tend to keep it at around, not too much of positive balance, maybe net neutral balance. So this is about the general COVID approach management protocol. So we can discuss any doubts on this with our experts who are present here, and then we can move to the sepsis protocol, and we'll take it from there. So thank you very much. I'll just stop.